Welcome to Yesterday, Today, and Tomorrow. I'm Len Mort,
And I'm Dorrie Cronin.
and together we try to bring you informational programs and things that are interest to everyone in the community. And speaking of the community, Dorrie, what have you seen going on lately?
I see a lot of people standing in the center of town holding signs.
You see those too?
I do see those.
Well, it's kind of great to see that every time, this time of year.
Do you wave to them?
I wave to them, yeah. Matter of fact, I'll be one of them tomorrow, whether it's rain, sleet, or snow. I'll help them hold some signs. I usually do that.
Yeah.
You're welcome to come down and do that too.
I'll be working.
You see all your friends and neighbors there.
I know. I see everybody when I drive through the center of town.
I see on Facebook that you took your daughter to a interview at a college.
Yeah, we went to go tour UMass Lowell. She wanted to go see the new engineering facility that they have there because she'll be graduating next year. So she's got to kind of decide what school she likes.
Wow, time flies, huh?
I know.
You know, when we started these programs, she was about so high.
Both of them.
Yeah.
Both of them. And Morgan's like 5'10" now. She's the tallest of the family. Playing basketball and keeping busy.
A couple of giggly girls, and now one wants to be an engineer.
I know. Crazy,
it's
isn't it?
Amazing how time flies. So, what else has been going on?
Not too much, just working and shuttling the kids around. How about you?
Not too much. Doing what I can do, you know, tied up with different committees I'm on, and tied up with St. Vincent de Paul with the food drives and so on.
Well, it's funny that you mentioned that too. Morgan just finished a fundraiser where they did a clothing drive for Cradles to Crayons. She was part of Project 351. So she had to coordinate a clothing drive, and we had to get all that together. So we just wrapped that up last weekend as well.
Excellent, excellent. We'll be doing a clothing drive. We do two a year, one in the spring, one in the fall. And we got one gal on St. Vincent de Paul that usually coordinates that. I give her a hand. And we've filled St. Vincent de Paul's trailer 3 times last year.
When is your spring one going to be?
That'll be coming up pretty soon. They haven't set a date yet for it, but it should be coming up, you know, sometime in May.
Okay, because even though we cleaned out our closets, we found some more stuff that we can get together for you.
It's been going well since we started putting these together. And the first year, I think we filled 1 trailer. And the second year, we filled a trailer and a half. Last fall, we did 3 trailers.
I know the last time when we dropped off some clothes, I saw that it was really busy because there was a few cars waiting.
Oh yeah, it was like an assembly line.
Yeah.
People bringing things in. You know, I thought it was a drive-through at Dunkin' Donuts.
Well, the way you have it set up is really good, though, that they can just drive through. But you know, it's even funny with the clothing drive that Morgan did. I mean, some people went out and bought brand new clothes to drop off for her.
The same with us. We had tons of clothes and dresses and women's jackets and stuff. We still had the price tags on them.
I know, it's crazy.
Oh,
People
amazing.
can be really generous.
Absolutely, absolutely. Yeah. And the good thing about that is that all those clothes go into Worcester to help those in need. And there's a thrift store on Park Avenue. And people can purchase clothes in there for a very low price. Mm-hmm. And if a family is in desperate need and can't afford it, we can issue a voucher where the whole family can go in and they can pick out clothes and at no cost.
That's great.
You know.
The foundation that Morgan just did her clothing drive for, too, they do the same thing. They actually set up, it's more geared towards children, mm-hmm. but they take clothes for adults as well. But they set up, you know, like a week's worth of clothes for a child, and it's specific to a child. They pick, you know, spring clothes, summer clothes, and they put a whole bag together for them. So
it's amazing what's involved. You know, 5 or 6 years ago, I wouldn't have paid too much attention to it, but being involved in St. Vincent de Paul, you get to see the needs of people, mm-hmm. and the response from people on the outside that will supply those needs, take care of those needs, you know, and it's amazing. Millbury is a fantastic community for that. You know, people step up and help everywhere they can.
Yeah, it's been great.
It's
been great. Now we have springtime coming finally.
Yep. And the trees are blooming, the flowers are blooming,
Yep.
and so is an allergies.
That's true. Itchy, watery eyes.
Oh, tell me all about it. I've had those for a long time, and the sneezing and the scratchy throat from
Yep.
the nasal drip, and it just doesn't end,
Mm-hmm.
Fortunately, there's medication for that, and you can try to control it somewhat.
Yep.
A lot of people that have a difficult time trying to control it, though.
It's true. And it's funny how the seasons change. Like one season you might not be affected so bad, then the next season it hits you hard.
I get it right through the spring, right into the winter.
Yeah.
The only relief I have is when it starts snowing.
Yeah.
So what else is going on? Anything exciting for you?
Nothing exciting.
No?
Boring life. I don't
Boring.
know what I'll do when the kids graduate.
Well, you're not going to get the empty nest syndrome when they all end up getting married and move off.
I will move with them.
One of my children, my youngest, he said to me, because his mom had passed away, and, I raised him, and he said to me, "Daddy, I'm never going to leave you." He said, "I'm going to stay with you forever." And I said, "Jeff, there may come a time when I'll ask you to leave," And he beat me to it,
I know, when we were looking at colleges too, I'm like, well, look at Worcester State, then you can live at home. And Ashley's just kind of like, she doesn't want to live at home.
No, wants that break.
She does. Well, she wants the adventure, the being in a dorm or having a roommate, experiencing something different. So.
Well, there's a lot of beautiful things to see, especially in the spring and year-round.
I know, the flowers are starting to bloom.
Well, some of them are gorgeous.
I know.
And I've got all those yellow flowers I'm seeing in my yard.
Those are my favorite.
Oh, well, you can come and get them anytime. I think they came from your house to begin
Ashley
with.
said that's what she wants at her wedding.
Dandelions.
Dandelions.
Well, I could understand if it was a dandelion wine, but dandelions, no.
I know.
Well, the interesting thing that we're here for, and we try to bring to the community interesting programs that affect everyone around. And we have a special guest today.
We do.
We do. And we have with us Dr. Melvin Deffrin from the Vitro Retinal Associates. And
Close enough.
Dr. Deffrin is not only a guest, but he's my eye physician. And we're going to talk about his specialty today. And that's AMD, Adult Macular Degeneration. Welcome, Doc.
Thank you. Glad to be here.
And, we never would have met if it hadn't been for our eye doctor here in town, Dr. Pialtos. I was having a little problem with one eye, and it seemed that as a pinstripe or an old school sign letter, it made it a little difficult, because if I looked down a pinstripe line on the side of a vehicle with my right eye, it looked perfect. But if I went to the other end of the vehicle and looked with my left eye, it was crooked in many spots. And I went to the doctor, and the doctor said, we seem to have some underlying issues here. And he sent me to Dr. Deffrin. And I'll let Dr. Deffrin talk a little more about that now.
So what Len is describing is age-related macular degeneration, which is actually in this country, in the Caucasian or white population, the leading cause of central vision loss, more than cataracts, glaucoma, and diabetes. So it's a major both economic and personal problem. It affects people over the age of 50, though the majority of eyes that get involved are probably in their 70s and 80s. At age 80 and up, about 12% of people have advanced disease. So macular, first of all, let's look at the anatomy a little bit. So we're talking about the retina, which is the nerve layer that lines the inside back of the eye. If you think of the eye as a camera, in the days when there was film, the retina would be equivalent to the film, or these days a digital sensor. So it's really the part of the eye that you see with. The macula itself is a very small portion of the retina, about a little more than 2% of the entire area of the retina, but it's the only portion of the retina that's capable of reading vision. And so it makes up really the most important part. The remaining 98% of the retina is really used for peripheral vision and night vision. And if you look at the representation of the macula in the visual cortex, the area of the brain where vision is processed, that 2% is really represented by about 50% of that area of the brain. So small but extremely important. And because of its small size, it's easily susceptible to damage. And from the name, macular degeneration is basically age-related, and that's really the primary factor. There are some secondary factors that have been involved, one of which is genetics. Smoking has definitely been implicated in macular degeneration, and other things that affect your health, like obesity, high cholesterol, are all contributing factors. Unfortunately, at this point, we have nothing that's preventative for people who have no macular degeneration to try and prevent that from occurring. So why don't we talk a little more detail. There are two subcategories of macular degeneration, what we call wet and dry. The vast majority of eyes, 80 to 85%, are dry, meaning that there's degeneration occurring, but no evidence of abnormal blood vessel growth, which can cause a rapid decline in central vision. So that's the 10 or 15% of eyes that we term as wet. So unfortunately, at this point, for people who are dry, which is the majority of people, we have no treatment available, though there are some clinical trials going on right now looking at reversing that situation. But there has been a real revolution in our ability to treat wet macular degeneration. Over the past 10 years, we've made really big strides in being able to maintain and in some cases restore lost vision if caught early enough. And that prior to this, many treatments were tried, nothing ever worked. So if you developed wet macular degeneration, it really meant permanent loss of central vision. So today, again, as I said, if caught early, some of that is preventable. So we're talking about medications that have come about in the last 10 years, all of which unfortunately need to be injected into the eye, but are very effective in stopping leakage from blood vessels, usually.
Been there.
But even in eyes that where we're unable to completely stop the leakage, we can at least prevent further vision loss. So that has been a real revolution in our bill. We've gone from nothing to something very dramatic.
Now, my mother, I've been a smoker, and I haven't smoked for 28, 29 years now. And my mother was a heavy smoker. And my mother had macular degeneration. And all she saw was shadows. You know, she couldn't make out much of anything. She couldn't read much of anything. And so now this goes back to, we'll say, 25, 30 years ago. What did they have for that then?
Nothing.
Absolutely nothing.
Absolutely nothing.
So they've made great strides in the last.
Yes, except we're only helping the 10 or 15% of people who are wet, which leaves the vast majority who are not. And so we're hopeful that that will change. There are drugs in clinical trials, some of which look very promising, and stem cell research holds out a lot of promise also. And that really, truly may be the answer. You know. So it's a little late in coming, but it's never too late.
So you're actually sticking a needle in there, right? Does
For
it go
treating, yes, we are.
And let me tell you, when the first time I went, it was with your partner.
Yes.
And I was so apprehensive. I don't think that, you know, a bottle of any kind of a drug would have helped me, you know. And I clutched the edges of that chair so tight I thought I was going to break my fingers on the chair. But it was a piece of cake.
Yeah.
Absolutely a piece of cake. And, you know, there was no pain whatsoever. Just a little pressure, like if you stuck your finger against your closed eye and pressed slightly. You had a little pressure.
But you can't see it coming?
No, actually, you're actually looking away
Okay,
when we do that.
okay.
So it's a needle that goes through the sclera, the white part of the eye, and you're looking away. Takes a split second to do. And as Len said, it's really very much a simple, nothing procedure. Very hard to convince people of that when I first describe it. But once they've done it, you know, they
'Cause
realize.
I know we have a hard time just putting eye drops in our eyes.
Right,
Because you anticipate it in your...
right.
So absolutely nothing to concern or worry about if in case someone had to have that. Because they medicate the eye and you don't feel it at all. You know, they kind of numb it.
Yeah, unfortunately, pills and drops don't do the job.
Yeah.
You really have to get the medication close enough to the retina to be absorbed.
And what does it do? Like once it gets in, does
So
it just...
one of the factors that causes blood vessels to leak is a protein that circulates in the body called vascular endothelial growth factor, or VEGF, which is important for the normal operation of the walls of blood vessels. But we think in certain conditions in the eye, such as macular degeneration, there's too much of it, and that stimulates leakage. And so these drugs belong to a class called anti-VEGF, and they actually inhibit the action of that protein and prevent it from working on the blood vessel wall. So, and it's something, unfortunately, that in the vast majority of eyes needs to be repeated. There are few eyes where it's a one-and-done situation, one injection and it never leaks again, but unfortunately that's very much the minority. And so for most people, it's an ongoing process. It's certainly an ongoing process of watching, both from the patient's point of view and from the physician. The trend is to need fewer and fewer injections as time goes along, but it's a lifetime of watching until we learn to do something better than this.
Here's a good question. Who thought of this? Who thought, let's stick a needle in there? You know?
So, I mean, a lot of people had a theory about why these vessels started to leak to begin with. But really the father of intravitreal injections is really a physician at the Bascom Palmer Eye Institute in Miami, Phil Rosenfeld. And these drugs really had their start in cancer therapy, and they're still used for that. And he realized that in cancer treatment it inhibited blood vessel growth. And he said, well, why shouldn't it work in the eye? So he had the courage, with hospital approval, to actually inject the first drug intravenously, which unfortunately is fraught with a lot of complications. But he was successful in halting the leakage. And then based on that, he said, well, what if we injected it directly into the eye? Maybe we could avoid all the systemic potential complications. And he did, and it worked, and off we went.
It's pretty amazing.
So,
I know that my first visit at your clinic, that I was told that, you know, it could stop everything. It could make an improvement, and it could possibly not do anything.
or keep it from getting worse.
Right. And would you like to explain what it has done for the people?
So in the clinical trials that preceded FDA approval of these medications, about 27 to 29% of eyes actually had significant visual improvement, which left, a little over 70% where the best that we were doing is keeping things from getting worse, which is certainly not a bad thing. I think the eyes that have the best chance of improvement are, number one, those that don't have significant damage from dry macular degeneration, every eye starts off dry, and 10 or 15% convert. So if there's not significant damage and they suddenly develop a leak and they recognize that there's a problem and are seen and treated, those are the eyes that have the best potential for improvement. Unfortunately, many people, because of human nature, we're all guilty of this, say, maybe it'll go away, you know, and they sit with it, and then they come in, and it's, you know, it's hard to undo damage that's already been done. Or they've had already some vision loss from dry macular degeneration, and we have no way of undoing that. So it's a whole spectrum of eyes that we see.
Now, what have your eyes done? Have they stayed the same? Have they gotten better?
I believe, and the doctor can also comment on that, but I do believe that there is somewhat of an improvement, not a great improvement.
Right.
And I believe that, am I correct, that it probably won't get much better than that unless
Probably not.
a divine miracle.
Right.
But at least it's been stopped.
Right. And fortunately for Len, only one eye is significantly involved. And so he sees well out of the other eye. And at least we're basically in a holding action with the eye that is involved. You know. So, and I have a number of patients who, in that category, where, you know, I'm injecting every visit, and every visit is every, you know, 6 to 8 weeks. And they understand that it's at least maintaining their vision, even though, you know, they need the injection and it's not getting better, but not getting worse. And many of those patients are functionally one-eyed, where the other eye has really suffered more of the ravages of AMD and are left with central scar tissue and not functional visually. So certainly there's a lot of motivation to keep coming, and even with the injections.
I've been really interested in looking at the scans of my eyes from the past and the present. And
yeah, so that's a diagnostic modality called optical coherence tomography. And it's really the prime diagnostic tool that we use with macular degeneration. And what that machine does, it uses a low-power laser to scan the macula thousands of times a second and creates an image of the cross-section of the macula. And it actually shows us all the microscopic layers in the retina and shows us where the damage is and whether there's any fluid either within or underneath the retina. And so really based on that, we determine the need for injecting or not injecting. And there are different approaches to injection also. In the clinical trials that were done originally, everyone was injected every 4 weeks for 2 years, whether they were leaking or not. And some of that was to determine a safety factor. But very few physicians do that in the real world. That's a real burden on people, both people and the physician. So we've come to really 2 ways of doing this. There's the as-needed approach, which I use a lot of, which means if it leaks, we inject. If it doesn't leak, we watch. And then the second modality is called treat and extend. And in that situation, what's done is every time you come in, you get an injection, whether it's leaking or not. But if it's not leaking, then the interval to the next injection gets extended. And so some people, instead of coming every month, are coming every 3 months, unless they leak again, in which case things get shortened once more. Both methods seem to be effective, you know, so it's more personal preference. You know, even though we're treating macular degeneration, it really creates a big burden both on patients and physicians. So we're seeing you now very frequently, whereas in the past where we could do nothing, we used to see you pretty infrequently, you know, like once every 6 months. So now we're seeing people 4 weeks, 6 weeks, 8 weeks. And so that's a burden, not only coming to the office, transportation, relying on family members or friends to bring you, And from the physician point of view, it's really increased the traffic through the office. So we're seeing people so much more frequently that it's really gotten overwhelming in terms of the scheduling. But it's still worth doing.
Yeah. So when you get treated, you can't drive, obviously, right after.
Well,
Or
it
could
was,
you?
He could, I mean, especially if the other eye is seeing well, you really could. But a lot of
I've
people
asked
feel
Barbara to let me drive home on the expressway, but I don't think she wants that because both eyes were dilated.
Oh, that's true too. Right. So,
can see
so it
most
is,
of everything.
so it is a burden.
Yeah.
And then there's the burden on the economy, because these drugs are very expensive. And we're looking at the cost of the drug for physicians to buy each injection varies around $2,000 per injection.
Which brings
Okay.
me to another question. Is it usually covered under?
It's usually covered by insurance. And in the few circumstances where, one, there is no insurance, or two, the secondary insurance. So, for example, people have Medicare, and Medicare always covers this. If it's an FDA-approved treatment, then Medicare is obligated to cover it by law. But Medicare will only cover 80%. And so most people have a secondary insurance to pick up the remaining 20%. But not every secondary insurer will do that for injections.
Right.
Or some people have, because they can't afford it, have Medicare only. And that leaves them 20%. 20% of $2,000 is $400 every injection. So in those circumstances, the companies that make these drugs actually have a program where, one, they go and talk to the insurance companies ahead of time, and two, if there is this gap, then there are charitable programs that will actually pay for the drug or pick up the deductible, which has been a huge benefit for lots of people, unless you make too much money, in which case you pay for it. But that's really the minority of people.
Right.
But it's an enormous financial burden on the economy because of so many people are getting injected. The highest expensive drug users in this country today are oncologists because of chemotherapy, and retinal specialists because of these drugs. So there are 3 drugs that have been approved, two drugs that have been approved, and one that's an off-label situation. And the off-label drug is the one that was originally used, and that's the one that was used originally for chemotherapy. So if you're the bottle for this is a drug whose commercial name is Avastin, and the bottle of Avastin says for colon cancer, doesn't say for macular degeneration. Okay, so the FDA has approved it for colon cancer. It's legal to use it for another reason, but it's called an off-label use. And surveys of retina specialists in the country, even today, even though we have 2 other drugs that work very well, easily 80% of retina specialists will always start with Avastin for 2 reasons. 1, it usually works, and 2, it's inexpensive. So even though it costs $2,000 or $3,000 to buy the vial, you get 400 doses out of the vial.
Okay.
That has to be done by a compounding pharmacy because it's a sterile procedure. So that brings down Avastin to the $40 to $50 range versus $1,800 or $2,000. So we always start with Avastin, and if we don't like the response we're getting, then we switch.
I know that we started with one, and then we went to a different drug because that one seemed to, go so far and then just hold its own.
Yeah.
And then the other drug did a little more, and
So we're
then
on the
that
third
held
one
its own,
now.
and I think we went back to the first.
Yeah, so we'll switch, I mean, there's not a huge scientific reason for switching, but it just seems sometimes some eyes develop tolerances, and switching can make a difference. And there are a number of other drugs that are in clinical trial right now for macular degeneration, for wet macular degeneration, so there may be something better around the corner.
Do you find that in these times that there are more people coming in with
Well, I think,
AMD, or, well, there's a lot more people getting old. So.
well, that's true. That's probably the major factor. And this has become a very interconnected world because of the internet and Facebook, and the information is out there. And a lot of people, a lot more people are aware, you know. So I think we do see more people now. And plus the community physicians are more aware also and don't hesitate to refer in people with macular degeneration.
Now, what would you say, because it's like you said, a lot of people put it off. I mean, some people would just say, oh, I must be just getting old.
Well, what's
know,
really amazing is someone who's had the issue in one eye and lost vision, and then something starts in the other eye and they ignore it for a while, which is a little incomprehensible, but I see it all the time.
Yeah.
So
what would you tell people to, like, when would you say, I mean, everybody should be having regular eye exams anyway.
But if you notice a change, and there are ways of checking your vision at home, is to call right away. And if someone calls and say, I'm getting distortion, my vision is suddenly dropped, I have a blind spot that I didn't have, I'm suddenly having trouble reading where I could read before, then they get seen right away.
So any sudden changes are
Any
the
sudden
biggest red
changes,
flag.
yeah.
I know that, I started noticing it in my work. It didn't affect my work because when I looked at things with both eyes,
right.
I could, place a brush in exactly the right spot. But if I looked with my right eye, everything looked fine. If I looked with the left eye, now everything was squiggly. Mm-hmm. And I noticed that in watching...
So one pinstripe on the side was fine and the one on the other side was...
Yeah, it kind of dipped down a little bit, But I noticed that watching TV that in some cases that faces were grotesquely distorted.
Right.
You could not identify who they were.
Right.
Maybe you could by their voice, but by their the visual, they were grotesquely distorted. And I noticed that when you looked at a horizontal line, it
was a dip.
Would dip one way or another.
Right.
And the same with a vertical line. And I know that since we've been going through the treatments, it still does that, but not as much. Mm. And since we've been going through the treatments, I've noticed that sometimes I'll be watching the TV and I'll close my right eye and I have a little more clarity than I had previously, but it doesn't last.
So it's somewhat a function of how much fluid is present underneath the retina. So when the retina is swollen, the nerve endings that sense light, the photoreceptors, get splayed out. Okay. So instead of being perfectly parallel, when the retina is swollen, they splay out like this, which means that the same image that used to fall on many photoreceptors now only falls on a smaller number because they're further apart. The brain interprets that two ways. One is distortion, and two is the image looks smaller. And so if there's less fluid, there's less of that, and that's what you're noticing.
And then the other part of it is the dark spot in the center of the eye, which you try to look at something directly, and, there's a circular spot there.
Yeah,
and sometimes when you wake in the morning and you look at the ceiling,
you'll see
it's very light.
Oh.
Yeah.
It's not, it's just like a little cloud.
Yeah, and then it fades.
Somewhat.
So,
yeah. And, but your peripheral vision is a little clearer.
Yeah.
On
So,
either
I mean, that's
side.
important to realize that macular degeneration doesn't lead to true blindness because the peripheral retina never gets involved. Unfortunately, the macula itself is the only part of the retina capable of reading vision. So reading gets affected severely, can get affected severely, and driving. And in today's society, that accounts for 90% of the things we do. So it's certainly a significant handicap if both eyes are significantly involved. If one eye is pretty normal, then not so much.
Well, hopefully my right eye will continue the way it is.
That's right.
Like I said, my mother, she couldn't see a thing, or either eye, because it was just shadows. Yeah. That was it.
So there are many people who unfortunately have leaks underneath both maculas, and we're treating both eyes. But the majority of people, it's a one-eyed situation where there's macular degeneration in the other eye, but not severe enough to impact the vision significantly, so that they can still function pretty normally. And then that brings us into, what can be done when both eyes are involved and people are struggling to read or watch television or even drive. And so there are adaptive devices that fall into the category of low vision aids. And there are physicians, usually optometrists, who are trained in low vision that we refer patients to in that situation. So we're talking about magnifiers of various kinds. We're talking about electronic magnifiers, readers. A key thing with reading, whenever there's any retina issue, is lighting. And general room lighting is usually not enough for someone to function with. You really should have a task light that's aimed right at the reading material. It makes a world of difference, even without magnification. And then in more extreme cases, there are talking books, large print. So there are things that are out there. Unfortunately, most people's expectations when something happens like this is, do something for me that makes it normal again. And we just aren't able to do that, So it's a frustrating situation.
Now, I do notice that driving at night, and a lot of times you might be able to say that the cause is the new headlights that they have.
And glare.
But I noticed that most lights at night have a tendency, and especially in the left eye with the macular degeneration, glare.
Yeah.
And it's to a point where you want to kind of turn away somewhat
Right.
in order to see where you're going.
Yeah. So there is something that you can do for that. Lightly tinted yellow lenses can be used at night because they're not dark enough to cut the light down, but yellow actually does a very good job of removing glare. So I have patients who weren't able to drive at night and wear light yellow lenses, and they can. It can make a difference. So
I notice sometimes when it's raining,
yeah.
the ground's
Right.
wet, and
Yeah.
then it's
Yeah.
nighttime. It
So
makes
I
it
mean,
very hard.
human eyes are not adapted for night.
Yeah.
Human eyes are daytime organs. The macula is purely a daylight organ, and the rest of the retina is useful at night. It comes down to different types of sensors in the retina: the rods and the cones. The cones are the only one. The cones are the majority of the photoreceptors in the macula, and they're the ones that are capable of color vision and fine vision, whereas the rods are predominantly in the periphery of the retina, and you can't read with your rods. You can see, and that's what you're using at night. And so night vision, for that reason, and also because lighting at night is towards the blue end of the spectrum, and blue light is bent, if you use a prism, blue light is bent much more sharply than the red end of the spectrum. And so blue light comes into focus inside the eye, in front of the retina instead of on the retina. So everyone is physiologically somewhat more nearsighted at night than they are during the day. So you have that, and throw a retina issue on top of that, and nighttime's challenging.
That's actually pretty interesting.
It is. I know that I've met while waiting, for a scan in your office.
You wait in my office?
Yeah. Patiently. And I've met a few people that come from Millbrae, so I'm sure that there's quite a few people here in the community that have this issue.
Oh, sure.
And are being treated, maybe by you or somewhere else, and other people in the community that are in need of treatment but don't realize it at this particular point,
Right.
because a lot of times you don't pay any attention to your eyes. You'll see a little blurry, so you'll rub your eyes a minute.
And I need new glasses, or maybe it's a cataract, or, Yeah.
Or you'll wear the same pair of glasses for 25 years and not
Or when
go
your
and have
arm's
them
reach
checked.
isn't quite enough so that you can focus.
You have that
he's
problem
beyond
too?
that.
But, people should really pay a lot more attention to.
But that applies to the rest of their body also.
It
you know.
does.
So we're all guilty of that to some extent. You know.
in every way, shape,
Yeah,
form,
absolutely.
you know. And I thought that it would make an interesting program for our viewing audience, and hopefully that this program will be distributed to a few other communities where people will be made aware of what's going
The awareness is the
on.
key thing.
Yeah.
Lately, you see some commercials on TV about AMD.
You do. The American Academy of Ophthalmology sponsors most of those. I think Bausch and Lomb. Oh, let me just mention vitamins. So even though we have no preventative medication for people who have moderate to advanced macular degeneration, there are certain vitamins and minerals that have been shown to slow the progression and certainly worthwhile taking. So there are a couple of brands. The most prominent one is Bausch and Lomb's, which is called PreserVision, as in preserve vision. So we always encourage everybody with macular degeneration to take it. You know, family members who accompany the patients always say, "I should take it too." I said, "No, you really shouldn't," you know, because it has no preventative effect.
Yeah.
It's too bad that you can't have something to prevent it.
Oh yeah, absolutely.
But then again, you know, you can't prevent a cold or anything else. But you can't prevent it, but you can actually, you know,
But
take
you can
the
do,
step
I
to
mean, there are
treat it.
lifestyle modifications that are worthwhile, you know. Things that you would do to encourage heart health all apply to macular degeneration. You know, low-fat diets, omega-3 fatty acids, not smoking, lowering your cholesterol. There's some feelings that maybe the statins that are used to lower cholesterol do play a positive role in macular degeneration also.
Now,
So is it actually a proven fact now that as a teenager looking at girly books does not cause that?
It causes your eyes to cross.
Okay.
no, I was going to say, does the senior center have eye screenings still? Didn't
I
they used
really
to?
don't know whether they do or not, and that would probably be a good thing for them.
Yeah.
You know, I can mention it to Judy when I see her. I'll most likely
I
see
mean,
her.
they do a
and so-
lot. They do a lot for the
They do. They
communities.
have other screenings over there for seniors, and
You know, blood pressure and things like
Mhm.
that.
I don't know what they could do in a particular senior center or something like that for screening.
Yeah, I mean, there are things that you could come in and do. You know, you'd have to dilate. You know, the problem is, you know, if you're putting drops in, that's already a semi-invasive procedure, and you have to have a consent situation. So it's a little more difficult than throwing a blood pressure cuff on and
Right.
pumping it up, which is totally non-invasive. You know, and then say, go see your
Right.
doctor. You know, so it's a little more difficult.
Yeah, I would
Yeah.
think so. You
Yeah.
know,
But the awareness and saying, I really am not seeing well, maybe I should see somebody,
Yeah.
You know.
Set some time aside for yourself and
you know.
and I've had a lot of friends of mine or clients who mentioned that boy, their eyes are really bothering them, and you know.
And most of the time it's nothing.
Yep.
Or something very simple, but occasionally that's not the case.
I know. Well, what about floaters and items like that?
So that's also another age-related
Okay.
situation, unrelated to macular degeneration. So floaters are parts of the vitreous gel that fills the space in front of the retina that become less transparent and visible as the gel ages because it liquefies. So to some extent, everyone has floaters. Sometimes there's a dramatic increase when the gel actually contracts and pulls forward away from the retina. And in those situations, you worry about that having created a retinal tear or potential retinal detachment. So, I mean, we encourage people to get looked at, but in the vast majority of eyes, it's a pretty benign thing. Annoying, but benign.
So what do you think, Dorrie?
Don't get old.
I think I need to go get my eyes checked.
No, you need to stop aging.
I wish we could all do that. I'd like to be 29 again. You know, I'm halfway to 150, so I'd like to change that. But
Yeah,
you know.
the first half was the more difficult.
I'm looking forward to the second half. I haven't upset enough people yet.
Ah,
You know,
there you
so
go.
it's still on my list. So.
There's the motivation.
There you go. There you go. Well, Doctor, thank you for coming.
Yeah,
Oh, my
very
pleasure.
interesting.
My pleasure.
And hopefully that people in the community will find this of interest and will make it a point to make an appointment with the local physician, have
Right.
their eyes checked, and make
Right.
sure they're...
And just not ignore things.
Yeah, don't ignore them.
Yeah.
The eyes are the most important thing. You don't want to... I'm fortunate because you stopped it. And so I gave up my Braille driving lessons
Right.
at the Bump and Grind Driving Academy. So I really appreciate it, you coming, Doctor.
My pleasure.
And talking.
Happy to do it.
And what's next, Dorrie?
Don't we end with words of wisdom?
Words of wisdom. It's funny you should ask. You know, words of wisdom, and I think that you'll appreciate this, and especially after you know who made the statement. Of all the senses, sight must be the most delightful. And that was by Helen Keller.
Who
And
should
with that,
know?
Who should know? Yep.
Right.
we'll see you next time.
I don't